So welcome to NUR 203 exam 2. I know after exam 1 and all those theorists, some of you didn't get all the grades that you wanted to get because they are difficult to remember and keep track of them. Hopefully by exam 2 and 3, we're going to get you understanding what you need to know. So we know exam 2 is a lot of information. It goes from week 4, 5, and 6. A lot of information, a lot of chapters. So I'm going to try to break it down for you so that you know what to do. We know that there's proctoring going on the campus. Always know that you have to tell your instructor 2 days before minimum. You also have to have the person on campus call in, or not call in, but send an email to the professor that has you as a student. And that communication must be done prior to an exam access code to be delivered. Just to let you know, just reiteration of that. So cognitive and sensory impairment, this was our week 4, talking about things that happen to children with our senses. So one of the things is eyes, amblyopia. You look at that picture, it tells the story. You've got one lazy eye. So what happens is your dizzy sort of vision. How do we treat it? Well, it's a muscle that is weak. Cover the good eye and make that bad muscle work. And that's all we need to do. Usually they put a patch on a couple times a day for a certain amount of time, and that will strengthen the muscle and it will correct. Rarely surgery. Strabismus is when those eyes, they can't go and focus to one point. I mean, if you put your finger out, both eyes go to that finger, okay? Yes, you have the dominant eye, but they don't. So one is going in each direction. So they look sort of cross-eyed, don't they? So it's basically eyes crossed beyond the midpoint. And again, this is one of those things that you'd see, that corneal light reflex. You would see an asymmetrical pinpoint light on the lights, which means they're not the same. And it's telling you you're not looking the same. Early cognitive impairment. This is a child who's mentally isn't where they should be for many different reasons. Well, many of them, Downs is one of the big things we think of. You see that dysmorphic syndromes, as in the child does look different. And we're going to go into that a little bit later. We know a child who has cognitive impairment is going to be irritable for no reason, many times because they don't know what they want to do, they don't know how to do it, and they don't know how to express to you why they're upset or what they need. And that's that irritability and even those behavior difficulties. Of course, definitely fine and gross motor delays. They're not going to be developmentally where they should be. They may not lift their head up till 6 months. They may not roll over to 7, 8 months. They may not sit till later on. And all of these things is why we do developmental screenings to find out where they are. One of the other things, of course, is the language. They're not going to be saying words by the first year. Even by the second year, maybe only one word, not multiple, up to 4 words, right? By 2 years. So they're not meeting any milestones. Now, Down syndrome, one of the ones a little bit dysmorphic. Look, I think they're adorable children. I've worked with them actually since high school, and I have a really soft spot in my heart for them. You're going to see those short, stubby fingers. You are going to see these big, round eyes. The one thing that's very significant is that tongue. And that tongue sticks out a lot, right? And that's why they have troubles with eating and drinking and talking and all of those things. What do you need to know about children? Well, their noses are flat. And because of their flat, all the mucus gets caught in there. And they have really frequent respiratory infections because the mucus gets caught. It's, the mucus is staph. You're always full of staph in your oral pharynx. And then it drips, and now you have an upper respiratory dripping and coughing, etc. They can't even blow their nose very well. One of the things that these children are prone to is cardiac defects. So we always check their heart on birth. Also, The other thing that we don't really talk about a lot is possibility for leukemia and hypothyroidism. So these children will need to have these checked up, thyroid levels drawn, of course, monitoring them for frequent infections and signs and symptoms of leukemia. Now, just like younger kids, any cognitive delayed child hospitalized is going to have really high anxiety. One of the reasons is that separation from the parents. So, as much as possible, we try to keep the parents with that child. It used to be we didn't let them into the OR. Well, today we do. For what reason? Is keep those kids calm. And when they're asleep, then we let the parents leave, right? Another thing that helps besides parents is that routine schedule from home. What time do you take your nap? What time do you wake up? What time do you take your bath, if at all possible? Following the same foods that you're eating at home, right? All of this, especially in your toddler, early preschooler, really helps decrease the anxiety of the child and makes hospitalization less threatening. Now, autism, we don't usually look at putting a label on a child with this diagnosis till after 2 years old. It is a lot of males that are autistic. What do we see? Now, we might see things early in age. Of course, we will, but we wait till 2 in order to diagnose them. You're going to see them, they don't want to look at you, or they're looking around and not at you. They're not going to respond when you call them. These are children that don't imitate those actions, like two kids playing together. One might imitate what another kid's doing. They don't. What they'll do is something over and over and over again. Repetitive behavior, taking a truck, putting it on a chair, taking something, putting it on top, taking another toy, putting it on top, looking at it, taking one thing down, the other thing down, truck down, repeat, truck up, put the other toy on top, other toy on top, wait, then pull them down. And it could go on 10, 15 times. This gives them comfort. Of course, we're going to see those verbal fine motor delays because cognitively they don't understand how to speak and how to do those fine motor and even gross motor. They're going to have behavior difficulties because their brain is stuck. They don't know how to express what they need, and they don't even know what they need. And how can they tell you? Because again, their speech is delayed. So these children like to play alone. They have aversions to textures. This has a lot to do with food a lot of times. They don't like loud noises. They don't like lights. They don't like crowds. But one of the things we must remember with any cognitive delayed child, be careful with safety, types of toys that you give them, or even making sure they're not going to hurt themselves. So safety, safety with these children because they don't know. Now, verbal milestones. Now, if a child is not speaking the way that they should, number one, you need to look and evaluate for hearing loss. Because remember, hearing and speaking go together. So if you're hearing a garbly voice, that could be something to do with their hearing. So this is one of the things that we'll recommend. Number one, by 2 months, these children are cooing and crying. By 3 to 4 months, they're more like laughing and giggling. And then by 8 months, they're imitating. In 10 months, uh-oh, here it starts. No, no, no. And then hopefully it's mama or grandma first, right? Hopefully it's a nana by 10 months in my house. It was the second, but all right, we'll took it. And then by 1 year old, usually they can say 3 to 5 words and they know what they're asking. Mommy, daddy, mama, dada, nana, milk, food, juice, whatever it is. One single words. And again, remember, always check hearing. Now you think of skincare, you think of the elderly always, right? Well, children do get decubituses because of, being debilitated and long-term hospitalization. So, number one always with skincare, though children doesn't matter, is good nutrition. They need that protein, right? They need those carbs and fats in order for their body to fight what's going on. Always use a draw sheet. Don't pull them because just like the elderly, you're going to shear their skin off, and it will happen. Skin moisturizers are good. Older kids might get a chuck, younger kids a diaper. Keep them clean. And then keep them turned every 2 hours. Use blanket rolls to keep them propped over. I use toys to prop endotracheal tubes. Just get them comfortable and feeling safe where they are. And these children do enjoy that. And by doing these things, using the blanket rolls and using pillows and toys, you are decreasing a lot of those pressure areas that could occur. So taking care of a hospitalized child can be tricky. Every kid is different, and every child is different the way they respond to diagnoses. And I think that's why I love pediatrics so much. It wasn't like every adult who has a gallbladder is all the same. Children are not. So you can't just remember globally a certain couple things. So first thing, try to assess a child, especially when I'm talking to younger kid, the ones that are into all of that separation anxiety and stranger danger, right? Well, number one, get the kid comfortable. I tell you to let them sit on their mother's lap or let a parent be sitting right next to them. Remember to sit not above them, to get below them. If they're on a stretcher or a bed, I'll sit down on a chair. I'm now below them. I'm not threatening. And of course, always base that examination on developmental level. If you're talking to a 2-year-old, have them use body parts. Where's your nose? Where's this? Use colors, use stickers, use whatever. I used to love to go to work to play. I would be inventive on how I would play and let these kids tell me what was going on. As I said again, making things really easier on the child, keep the child's routine, keep the parent there as much as we possibly can, because the biggest stress in the younger kids is that separation. Now, we do use play in hospitalization. And play tells us what's going on with that child. What is it that made them fear what's happening? And when we do that, we know that exactly what happened. So expressive play, this is a release of tension. Dramatic play is when something happened, whether this hospitalization or a previous. They can show through toys and equipment what went on and why they were afraid. And that's dramatic play. Very important thing. Excuse me. So dramatic play can help us understand. We can change the way we approach the child, and now it's not going to be as fearful, especially if that child has to do it again. And then creative play is just showing their emotions. If they're happy, you're going to see beaches and houses and trees and sunshine, right? And if they are not these happy things and maybe they're cross out lightning rods, whatever, something's going on and it tells us a story. So, caring children in the hospital. Now, we know that children don't tell us if they hurt. And the reason is they don't want to be stuck with a needle or they don't want that medicine. You have children like that. So we know some children will be in pain. So our responsibility is to make sure that they're medicated enough. And why? Well, post-operatively, a child needs to turn, cough, and deep breathe just like an adult, right? Get out of bed, use incentive spirometry. And what if a kid is not doing it the way that they should? Well, the first thing I'm going to say, are you in pain? And then make sure you medicate them. Now, not only should you medicate them before getting them out of bed, before doing all of these cough, deep breaths, respiratory treatments, etc., It's going to keep them calm and they're not going to remember pain in the hospital. Also, distraction. I used to have music going and I'd be dancing or the TV on with one of their favorite shows, or I'd have stickers asking which one they want. Distraction works on many age of young children, okay? So, one of the things, I worked in the cardiac intensive care unit for 10 years. Loved it, probably my favorite place ever. And we used to pull out a lot of chest tubes and it burns, it hurts. Now, I have done adults and I've done children. The adults tell me it burns intensely initially, and then it eases off and then it's gone. But don't ever lie to a child and tell them it's not going to hurt. Because even with pain medicine, it's going to hurt. But what you need to do, be honest. It's going to hurt, but I'm going to do everything to make it as little as possible. And it's not going to last all that long. And I'll be right here with you. That child will get through it. You haven't lied to them and you still have their confidence. We think that we need to give a lot of morphine and those type of drugs. Children respond very well to acetaminophen and ibuprofen. Now, we only give acetaminophen for the first 6 months of life, and after that, we add on ibuprofen. And the reason is ibuprofen's an NSAID, and NSAIDs tend to have bleeding problems, and the younger children can't deal with it. So we also say, to give acetaminophen, ibuprofen in between the big drugs like morphine because it really helps it. So a little bit all the time works well. And remember, any parent who's telling you that they're giving them aspirin for a fever, for an ache, a pain, remember, no child should be having aspirin unless it's that Kawasaki, right? Week 5 talked about Kawasaki disease, and we give high dose aspirin. That's the only time. Our goal is to keep this child as free of pain as possible. So you have an IV on a child. And if you have little, say you're in the newborn ICU, I've heard many of nurses, students want to go and work in newborn ICU. Can you imagine 50 mLs of fluid in a little 3-pound little baby? That's like the whole arm. So when we're looking at it, it should be done hourly. And look for that redness, swelling, blanching, leaking. And the first thing you do when you're in doubt, turn it off. Stop it immediately. If you can, and there's no caustic liquids in there, just regular fluids running through, take it out, put a nice warm pack on it, hospital approved, and elevate it. And let the physician know that there was an infiltrate, especially if it's quite large. Oxygen. Now, newborns get oxygen a lot at birth. They have something called transient tachypnea of the newborn, and it just means they need a little bit of time to breathe, and a little bit of oxygen helps it not to be so difficult. Infants do the best, if you can, in an oxy hood. If you look at the picture, it's clear. They can look around, they can suck their fingers, they can have a pacifier, and it is accurate. There's little O2 sensors in there, and there's nothing on the face to bother them. You look at all the other stuff, there's stuff in the face. And even that nasal cannula, they stick their fingers up, and we usually tape it to their cheeks. They rip it off. So now they're ripping tape, so oxyhood. Now, infants. How do we take care of infants? How do we get labs? They're special. Usually all lab draws, except for a blood culture or bleeding coagulopathies, are done by a heel stick. Never in the middle, because that's your bone. Your calcaneus bone is right there. We don't want it to get hit because that's osteomyelitis that can occur. So on the sides, what we do first is put a hospital-approved heel warmer on. It dilates it. And then we'll pinch it, and just little bits of blood is all we need. If you can imagine, a complete chem profile in the CBC is 1.2 mLs of blood. It's not much in little tiny tubes. And the one thing that most parents have a problem with, you have a child come in, possible urinary tract infections, we are going to do a straight calf. And why? Well, you try to put a bag on, you're catching all the contaminants, right? So it's not reliable. How is that child's immune system as an infant below a year old? Well, it's not that strong. So you want the first antibiotic to work. So that's why we do a straight calf. We clean the area, get it in, have the parents and mommy holding them, giving them a pacifier, or even breastfeeding for comfort. And these children don't even know. What bothers them the most is holding them down. So again, excuse me, family-centered care, hospitalization. We have children that have chronic illness, cystic fibrosis, sickle cell disease, cardiac conditions. They're in and out of the hospital. We know, I've said it before, I say it again, separation anxiety is the biggest stressor that we have, and keep the parent there. What we have found is the most difficult temperament are usually males, and usually about 5 months to 6 years. And as I said, cognitively impaired children will act out. They don't know, why is mommy gone? Why is daddy gone? They don't understand. We know that there's going to be all that separation anxiety, and we know there's that regression that goes on. Not uncommon for a kid to be incontinent, or sucking their thumb, or wanting a bottle instead of a sippy cup. All of this is part of it. And we know that it's because they don't want to be away from mom. They have to be for certain periods, and they're going through that regression. Now, hospitalized school-age children, again, how many times do I have to say it? Routine, 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 right? So structure their routine the way that they're doing at home. Also, a school-age child in for a longer period of time, have them have the teacher get notes from the other children in the class, send them in, and get the homework so that they can keep up to it. Now, otitis media, one of the most common conditions that, kids at upper respiratory, and of course it leads into those short eustachian tubes, and it goes up into the ears, and now we have ear infections. Acetaminophen is perfect for pain. Is that all you need? We know we can give antibiotic drops for the externa, or just both of them, and oral antibiotics for the media. We know that sometimes kids will get older and need tubes in because it's not draining by themselves. I just got a tube put in March, so I'm one of those persons. Now, one of the things that we know about otitis media, we can do some preventing, and that's by having children wash their hands, which they're learning really well since COVID. They're always washing their hands, alcohol things everywhere. Also, immunizations, making sure their immunizations are up to date does decrease the amount of otitis media, and then no cigarette smoking around children. Bronchitis, that is the most frustrating of all conditions for adults and children. At night, they have this dry, hacking cough, and it keeps them awake all night long. It's just cough, cough. I went to lay down and I cough, cough, cough. Non-productive, dry, hacking cough. What do we do with this? Usually, physicians will put them on some sort of cough medicine to calm it down. They may or may not, depending on viral or what they could think, or the child's condition, might put them on antibiotic. Rarely they have a fever though. Now, croup, upper airway, it is all inspiratory, stuff going in to get into the lungs, and the airway gets swollen. It is a virus. So this is just symptomatic, right? Tylenol, Motrin, fluids, rest. With croup and the swelling, we're going to be giving a steroid, which will decrease it. What's so significant about group, and if you ever work in a physician's office or ER urgent care, you can hear the child with group coughing. It's a seal barking. It is very loud and you will hear it. We know if they're abdominal breathing, we're trying to compensate because their difficulty with breathing. And we know that with croup, it's all about that inspiratory stridor, and we don't want it to get worse. So what do we do? Well, we'll maintain the airway. We'll give sometimes a nebulized mist with oxygen. Sometimes we give that racemic epi in an aerosol. It goes right down into, the airway, and it will help it on swell. And then, of course, the steroids, the anti-inflammatory. Sometimes it's one shot, one pill, or a multiple oral. All depends on physician and children. Now, you don't treat croup. Well, the swelling's going to continue, isn't it? Well, now your epiglottis is now swollen, and it's now covering the larynx. Air can't get in. Okay? Inspiratory, cannot breathe, which means they can't swallow. Because they can't breathe, their voice is like a frog. I mean, no cough, no cough. And you're going to see them start to get agitated. They're becoming hypoxic. Now they're sitting in that tripod positioning like adults do, looking for a place to breathe. This is an emergency. One of the things that we think that could be part of croup is the immunization of the HIV vaccine. Now, you get a kid drooling. That's the big word, drooling, muffled speech, inspiratory, like barely getting agitated. This is a suspected epiglottitis. You're going to go and take care of that child, and you're going to get somebody to get in there with an intubation and a tracheostomy tray. When you have these children, you will not put anything in their mouth. You'll put not going to do a throat culture. You're not going to do any of that. Not going to put a tongue blade in there. Why? Well, it increases the swelling. And maybe that little piece of air that you're getting in there, now it's swelled over. So usually with these children with that aerosol, with the epi, usually we can turn them around. I've never had to intubate before or put a trach in. Now, cystic fibrosis is an autosomal recessive trait. It means if both parents have a defective gene, 1 in 4 chance or 25% will have the disease. Now, sometimes we know at birth to suspect it. Sometimes we don't. So, cystic fibrosis, the first thing that we might see or suspect cystic fibrosis at birth, newborn, in the first 24 to 36 hours, there's no stool. And usually infants come out stooling, meconium, right? Well, these don't. We suspect what we call a meconium ileus, and it's due to cystic fibrosis. What will we do if we suspect it? Well, we're going to do that sweat chloride test. And what is that? Well, basically, the skin is full of salt. If the parent was to lick the skin, it would be high in salt. So never, ever take the salt shaker away. They are losing salt like crazy. Now, cystic fibrosis is about the pancreas and giving pancreas type of medicine, digestion. So whenever you're working with the pancreas, as these child gets older, they're going to be doing screenings for blood sugars, right? Because diabetes mellitus is a very, very common comorbidity on them, okay? And we know the kid as they get older is lifelong. It's not going away. As soon as we can, we need to have the children know, wake up in the morning, get your aerosol done, get your vest on, which is that big vibrating thing, cough up whatever mucus, take your meds, making sure that they use the pancreatase on their food, and just getting them involved. Now, what do you see? Well, cystic fibrosis is the clogging of mucus in the lungs and in the small intestines. And what happens is fat is not digested. We use pancreatase, but it's still, there's a lot of undigested fat. So what would you see? Well, there's going to be large, oily, it's all the fat, foul-smelling stool called steatorrhea. The fat's being lost. Well, we have fat-soluble vitamins, don't we? Well, they're being lost too. This child, because they don't digest fat, are going to be on the thinner side because they're not getting all their nutrition. So what are you seeing as a diet here? High protein, high calorie, low fat. Now, it affects the lungs, so wheezing, bronchi, dyspnea, and they're going to have a dry, non-productive cough. The mucus is down in there. We just try to loosen it up. And because it's mucus in there, it's like a petri dish. Bacteria love to go to it, infections grow, and multiple respiratory infections. So as I said, children need extra salt. They need high calorie, high protein diet because they need to maintain nutrition. They're going to have to get those vitamins, all the fat soluble vitamins, A, D, E, and K. They're going to be getting aerosols. Some are going to be mucus thinning ones. Some of them smell like eggs, rotten eggs, actually, but it's the one that really thins it up and helps them get out of there. They're going to be on hypertonic saline, bronchodilators, and usually those respiratory infections will treat with azithromycin. They, as I said, need to wake up. They need to do their chest physiotherapy, respiratory therapy, etc. Remember, it's done before they eat. Can you imagine doing an aerosol, opening the airways, doing their chest CPT? Usually it's that vest. You can see the pictures I've had here for you. And this is like making all of the chest jiggle and trying to open it up and doing deep breathing exercises. After you eat, you're going to vomit. Again, they're already struggling with nutrition. So do, especially even normal kids without cystic, whenever you do respiratory treatments, it should be before they eat, not after. And another thing is to clean their equipment. Remember, they have a petri dish for their lungs. So we want all the stuff that can come up into those respiratory masks. It can keep that infection going. So clean it every day. Soap and water, that's all. Now, as I said, nutrition is the other thing. Now, pancreatic medicines, pancreatase is the big one. 30 minutes before meals and snacks. That helps digest the food, right? There are little beads. They are enteric. We don't ever crush or chew those, all right? Now, we can sprinkle it on the food and get it down like that. Sometimes there's powder, just like some of those aerosols that we take, like Symbicort and Advair, those ones that are preventative, and we have to rinse them out after them. This is the same concept. It does eat the calcium and enamel on the teeth. So make sure that we rinse them out after. And I think in pediatrics, the one thing that we might tend to forget is to adjust the amount of enzymes as they grow. Some of these kids grow quick and they could have 5 pounds in a year, and it could mean that they need more of a dose. And I've seen that a lot, for instance, in seizures and seizure medicines. You know, they gain so much weight and now their meds are behind. So again, remember, adjust the enzyme for that normal growth. Now, as I said, cystic fibrosis attacks lungs and it attacks small intestines. In males, there's some clogging in their vas deferens, which means they cannot have a child. It's clogged. The sperm can't get to the mother. So some of these men, when they meet a partner and they want to have babies, they will do a bilateral lung transplant. And usually 1 year, after this transplant, apparently the vas deferens is no more with mucus and they're able to father a child. Females don't have a problem getting pregnant, okay? It's the males that can't give that woman the sperm for her to become pregnant, okay? Now, tonsillectomy is probably one of the most common things we do for children, right? Tonsils, adenoidectomies, and tubes. So, how do we take care of these children? Well, when they're waking up, have them on their side. Remember, they have taken basically a scalpel and a cautery and just scraped out those big tonsils. And what's left is big scabs that have been cauterized. So think of that. So they're going to have a little bit of bleeding in there. Have them on their side so that they bleed, it will come out their mouth. As post-op, make sure there's not irritating, no orange juice. I think that would be horrific. No high season foods, and keep them calm. I've actually seen a girl 7 days post tonsils who ended up bleeding, being rushed into the ER. She had just seen the doctor and she was vomiting clots. All right. So you got to keep them calm for 7 to 10 days, they say. Now, you need fluids, right? They're going to need those things. No red stuff. You want to know what's blood or not. Older kids, you can put an ice collar on. It's just around the neck and it helps. Younger kids won't do it. Any ice things, popsicle, ice chips, any cold things are great. Again, not red. These children are going to have an impaired voice, right? Those children are not going to be able to talk the way that they should. And again, one of the things with tonsil surgery, think about the age group that gets this. These are young, right? Aren't they like losing all their teeth at this time? So they could aspirate a tooth. So one of the things to keep in mind when you have a tonsillectomy going in, looking at their teeth, right? So with this sore throat, they may not talk, which, that's going to be a, problem, or they don't want to talk. And if they're swallowing, one of the things that you'll see is the back of the throat, they're bleeding. What do you do when your throat is full? You swallow. So if you see them swallowing, just slightly open their mouth. Don't do anything more than that, and you'll see a tongue full of blood. Older kids, it goes into the eustachian tubes and causes really bad ear pain. Let them chew gum. It's like going up in an airplane, right? Chew gum for the ears to pop. And again, as I said, loose teeth are that risk. Now, we have croup, which is all inspiratory. Air going in, it gets stuck in the upper airway. Asthma is the lower part. It's the lungs get swollen. So the air goes in and it gets trapped. So it's expiratory wheezing, okay? So it is a bronchial hyperresponsiveness. It would be do not do things you're allergic to. If you're allergic to grass, you shouldn't play a sport in the grass. If you are up north, one of my favorite times of the year, rake the leaves and burn them. Well, if you're allergic to those things, that would be ridiculous for a child with asthma to be around. What do you see? Well, these kids are coughing, coughing, coughing. And then you'll hear this expiratory. I mean, sometimes if you listen to their lungs, you might just hear a really small, like really just a squeak because their air is trapped there so long. And if they stop wheezing, air is not moving at all. That's your emergency. So prolonged expiratory phase. They're trying to get that air out and it's not working. And again, absent chest or absence of wheezing is your high priority. You should hear something. You want air movement of some sort. How do you treat it? Well, you have your rescue, your albuterol, Ventolin. Remember, there is a spacer for younger children that can't just push the button and squeeze in. They're adults who need the spacer. It's not a problem. If they can't breathe, always have a kid sitting up. If they're trying to lay down and they can't breathe. I can't breathe there anyway myself. So have them sitting up. And then corticosteroids, Solumedrol is given, and that really does help, with the inflammation, and that's for your acute stages. You also have Singulair. I call it the Claritin for asthma. And it used to be not kids, young kids could have it, but now they're down to 2 years old, is the last one that I heard, that they're giving Singulair as a preventative, okay? Remember, always with children with respiratory illnesses, exercise is so important. And I always say, because it's my favorite thing to do, is go swimming. They hold their breath, go underneath, and they're doing breathing exercises and don't even know it. Now, RSV is a common cold for you or me, but a kid under 1, what does a kid under 1 know how to do, especially your younger kids? Suck, swallow, and breathe. Now, put mucus in their nose, in their airway. They and their obligatory nose breathers. Now they can't breathe. So now it becomes a problem. Well, on top of that, put a kid who has CF, who has congenital heart defect, or was premature. These children really are having a problem with that. What are some signs and symptoms of respiratory distress in children? Well, that is nasal flaring. And in younger kids, you might hear the grunt on the end. That nasal flaring, that at the end of every breath, okay? It is contagious, like upper respiratory things. So those children that I mentioned that are at risk, high risk, those kids are going to be getting a once a month immunization called Synagis or palivizumab. It's a biologic, and it's only for the first year of life, and it's from early winter to early spring. And of course, you try to keep them away from sick people, but you know how that is. People show up. Another thing with older kids they might order for this to get and loosen the secretions is a cool mist tent. Now, sometimes toddlers don't like to be in this plastic, right? So having the parent hold the tube around their face, that can work too. Or sometimes I tell the parents to get in there also. Depends on the kid, parent. Now there's three sorts of pneumonia. We have that aspiration, where you fed them too much or they're not burping. And how do we prevent it? Burp them, don't overfeed, have them sit up. And then, of course, it's the other aspiration, smoking, chemicals, or baby powder that I love, but they can't be around it. Now, viral pneumonia, everybody's like, well, we'll give antibiotics and take care of it. It's a pneumonia. No, it's symptomatic. Any viral disease, especially viral pneumonia, you give the acetaminophen, ibuprofen, fluids, and rest. Bacterial is when you have the higher fevers, and you're going to give an antibiotic, and augmentin is your drug of choice for that bacteria. Now, mononucleosis kissing disease is viral. It is an Epstein-Barr virus, which sort of makes you down, tired, no energy. Epstein-Barr, usually you have a sore throat, you feel weak, feel flu-like. And with this mononucleosis, the biggest thing is your lymph nodes will swell, but it also can swell your liver or your spleen. The spleen gets like a big balloon. What the biggest thing from this disease is that these children should be advised to protect their abdomen and do not participate in contact sports. They can actually hit their belly and their spleens will explode and they'll die. So how do we treat it? It's a virus. Tylenol, Motrin, rest, and liquids. Simple as that. And protect that abdomen. Now, congenital heart defects. Everybody's scared about congenital heart defects. Telling you the exam isn't overly loaded with defects, okay? just to let you know that. What do you need to know? What does a child that have congenital heart defects look like? Well, many times we don't see things at birth. Sometimes we see it later on, and I've seen a lot of it with the coarctation of the aorta, where the blood is going back into the lungs and filling up because it can't go down to the body, to the feet. What would we see? Elevated heart rate, breathing really fast. You're going to see sudden weight gain, swelling all over, tired, exercise intolerance, which could be poor feeding, because that's their exercise is feeding. They could be diaphoretic, and these children are huffing and puffing because their lungs are full of fluid, okay? You have fatigue and rapid breathing because, suck, swallowing, and breathing is too much, and they're not getting all the oxygen they need because the lungs are full with fluid. So we're going to give smaller, frequent feedings, but we're going to increase the calories in that formula or even breast milk. And that will be a smaller amount of liquid, less time to eat, still getting nutrition. And we're going to limit those feedings to 30 minutes, okay? One of the things that I used to look at with getting admissions of these congenital infants, they're suspecting cardiac, and I see all these symptoms, and they're 2 months, 3 months old. I'm going to be checking for those pulses. I'm going to be checking for coarctation. And I'm telling you, 4 out of 5 infants I found with coarctation, which means no or minimal pulses lowerly, and the upper extremities are present, and blood pressures are higher because on the top because all the blood's there, and lower on the bottom because the blood can't get there, that kink in that coarctation. So those are your congenital defects. Coarctation is something to look at. Tetralogy of Fallot is one of those conditions where it is cyanotic, and what we treat that tetralogy Fallot is the knee chest when they go into spells, and then surgery. Older kids are just going to sit and squat down, pretty neat. And then transposition of great arteries is we're going to have to keep that duct open, that fetal circulation, that patent ductus arteriosus. So tetralogy is actually 4 different things. We know it's that tet blue spell. As I said, it's the knee chest or the older kid squat. And the biggest thing is calm the child. Can you imagine you all of a sudden have no blood going to the lungs? I have seen O2 saturations go from 100 to 10 in minutes. And an older kid, especially, is going to get all frustrated. So calm the kid down. That's number one. We can give morphine again to calm them. And then many times they'll put them on digoxin routinely to prevent it. And if it's an infant, as I said, knee chest. So patent ductus arteriosus. I told you we need that for something like the transposition of great arteries. Lungs and the systemic, they're no mix. There's no oxygen going to the body. So they need something until they do surgery. And what they do is say, well, we've got that thing that was there during fetal circulation called the patent ductus arteriosus. It connects the pulmonary artery to the aorta. Mommy keeps it open by the secretion of a hormone called prostaglandins. Well, when mommy's gone, so are the prostaglandins. But we have a systemic prostaglandins that we use. It's a slow, continuous infusion. It keeps it open. And what it does, it oxygenates, and then it allows the heart to beat and function. So prostaglandins is that key to keeping these children alive till we do surgery. Indomethacin, conversely, is that medicine we give when they're born with it. We don't need it, and we need to close it. and we can give it, it's 3 doses, and we will hear this machine-like murmur that's there when it's open. All of a sudden, it's going to close. And then that blood pressure, which is really wide, like 60/18, normal 60/40, it's going to go back to 60/40. Atresias and narrowing,
I'm sorry, you said it was what kind of sound?
a machine like a washer machine murmur.
Thank you.
It's sounds like a washer machine. It really does. Atresia, A, absent, without, no opening. Usually that's that tricuspid atresia, believe it or not. Never on the left side. It's usually between the right atrium, right ventricle. And then stenosis is that narrowing. That means blood is going through, but it's narrow. It needs to be more. You see aortic stenosis and pulmonic stenosis. As I said about chest tubes earlier and pain, make sure that we medicate. And to be honest with chest tubes, you do the before any pain medicine, you'll always do vital signs before, do the procedure, and then we'll do them after, just to make sure they're tolerating pain medicine. Transplants, it happens for children, and the greatest risk is your rejection. Digoxin is used extensively in cardiac children. Very hard to figure out if a child is in dig toxicity if they're an infant, but there are key little things that we look for. We know that digoxin slows and strengthens the force of contraction. We know that if a heart rate is below a normal range, that is possibility digoxin toxicity. Also, an infant might be vomiting. That would be a lower heart rate and vomiting. You're going to hold the dose, call the doctor, and find out what their level is. And giving digoxin is just like with adults. You're going to count the heart rate apically for a minute. You're going to look at their electrolytes, specifically potassium. Look for the last digoxin level. And what's their heart rate there? Now, a child comes in, we do an echo, and we see something. Well, every one of those cardiac catheterization. What is our job? Usually when they go, we don't have to do anything before. Many of these kids are fed up to 2 hours before. But when they come back, they have had a catheter in their right femoral artery and femoral vein. Many times the biggest complication is bleeding. The first thing I do is check that dressing. If I'm seeing bleeding, I'm going to take my 2 fingers, because it's usually an infant, and above it, I'm going to apply pressure and I'm going to call for help. Okay, bleeding is the big thing. Now, there's nothing they can do but stop the bleeding, right? But you'll call for help. Now, let's say the dressing is fine. You're going to look at the leg, you're going to look for pulses, and you're going to document that. That right leg should maintain straight. You don't want to do anything to dislodge that clot. Bed rest for 24 hours. You're going to be taking those vital signs. You're going to give hydration. And then, of course, the young kids, you want to monitor their glucose. Sometimes they haven't eaten, haven't got glucose, their blood sugars are too low. Sometimes they got glucose in a procedure, it's too high. So you want to know where you're starting. Rheumatic fever is due to a strep throat, right? Group B strep is what causes rheumatic fever. It attacks the whole body, fever, joint, rash. It swells up your joint nodules, and you can have this weird chorea type movement. Now, when we get a child with these symptoms, we'll say, what sort of illnesses have you had recently? And they might have said, well, I had a sore throat, or I had a strep throat. Well, we know that it's a strep infection. How do we treat it? Well, we're going to give a long course of antibiotics. Everything will be reversible except heart valve damage. And it's usually that mitral valve, and it usually will need repair or something. Now, this week's lecture is hematologic, okay? ITP, it's when you've had usually a little upper respiratory infection. And all of a sudden, we're seeing bruising. We're seeing petechial type of things on the, usually the legs is where I saw it. And they say, but my kid doesn't go out to play. Why is he bruising? So we'll do a CBC. Platelets will be below 20,000. How do we treat it? Well, we can turn this around. We're going to have to give IV immunoglobulins and anti-D antibodies. And remember, platelets below 20. You are highly concerned about bleeding. So avoid, if that child is going to be admitted to the hospital, avoid venipunctures at all possibility. Watch them for bleeding. They're having CBCs. What are those platelet counts? What are they? And then corticosteroids are sometimes given with it too. Anemias, iron deficient, megaplastic, hemolytic. Well, iron deficient anemia, this is all about not enough iron. Now, one of the things about anemias, and you don't have a high enough blood count, the biggest thing is all of lack of energy. They're exhausted because their red blood cells aren't there. There is no oxygen, there's no iron going to the body, so the body is tired. How do we turn this around? Well, we can give injections, iron, dextran, Z-Track, or we can take it orally. Now, many of this iron is in a liquid. Now, if they take it, gets it on a teeth, it will stain. So drink it with a straw. And because it's absorbed in the stomach through stomach acid, give it with orange juice. It helps it get better. Okay, orange juice, a liquid straw. Now, one of the groups of children who are at high risk for iron deficiency anemia are toddlers. Remember, toddlers are finicky, picky eaters, and they drink whole milk. No more iron formula, right? So these kids we have to be care of. Eggs, whole grains, and raisins are a great sauce. Now, megaplastic anemia is that B12 and intrinsic factor thing. All we'll say about it is when you suspect it, have them look at their tongue. Their tongue is beefy red. It's really bright, beefy, like red steak color. And then hemolytic anemia, I've seen this with some conditions. It just, the bloods just are destroyed, they explode. And a lot of times it's infections or, as I said, medications due to conditions. Sickle cell anemia are sickler shaped shells. How do we treat sickle cell? Well, sickle cell is a clogging in a vessel of these little sickle shaped cells, and blood can't get through. So we need to treat the cause of the sickle cell, and it's because the vessels are too small. No priority, IV fluids. And pain medicine second. Students want to give them pain medicine. You're treating the symptom, not the cause, okay? Now, Cooley's anemia is from the Mediterranean. It is rectangular shells type cells, and they just burst. And these children, when we talk, there's many different types of Cooley's anemia, thalassemia, but the one that we usually are talking about is the Cooley's, which is the worst type. And that ends up with blood transfusions. These children grow into adults and they need blood transfusions. And then aplastic anemia is when all the cells aren't working in the body. So back to sickle cell, we know we're going to give fluids. That's number one. You know, there is controversy about giving oxygen. You don't have cells. How are you going to carry red blood cells? What's going to carry oxygen to the body? Does it really help? Well, some physicians will say put it on, some say not. But that's one of those things. But what do we do with these children? You've got, these vessels are getting small, they get clogged up, and they create swelling and pain. Our goal is to prevent that. So, how do we do this? Well, always keep them well hydrated. Remember when they go up on a plane, they're in a pressurized cabin, right? Their vessels are going to get smaller. So, extra fluid would be one of the things that we recommend. They need to eat high protein, high calories in order for their body for nutrition. They need to be moving. They need to be getting the body movement with exercise. But remember, if they're exercising, to have rest periods and hydrate. Okay, big things. And then again, with any pain, make sure it's medicated before it's too bad. Now, HIV in children. One of the biggest thing about HIV, it usually comes with the infants through the mother, and it's given to the baby. Now, there are certain things that can occur older on, respiratory, GI, and tegumentary, and these are just these opportunistic infections. But our goal is in this child, is in infants, giving those antivirals as soon as they're born. And so our focus is on improving that infant's immune function. We want to give them good nutrition, right? The body works better. And then all of those other type of opportunistic infections, we try to prevent them. Osteosarcoma, it's a bone cancer. How do we treat it? Well, we're going to treat it by taking the whole femur bone out. You can't just take the tumor off. Usually, and a lot of times it's the femur bone. We have to remove the whole bone. So you're left with nothing to connect the knee to the hip, right? So what they do is what we call salvage the limb. And that helps put a place for a prosthesis. They'll do radiation before, they'll do everything to shrink it down, get it out. And again, everything is done to salvage that limb. Leukemia. Remember I said downs are at the higher risk for this one, right? Acute lymphocytic leukemia is when it's an overproduction of immature white blood cells, which means you don't have any immune system. So we know once it's diagnosed, you have no white blood cells that are working. And these children will come in with bruising and in pain. And we're going to start chemotherapy. There's different stages of chemotherapy, but in the first stage, called induction, is where we hit these children with usually 2 or 3 different chemotherapies in the first 4 to 6 weeks. And in that first 4 to 6 weeks, we get rid of the leukemia. Now, after that, there are different stages because there's always little sneaky cells that hide and seek somewhere, right? And we want to make sure that they're gone. But that first part, induction, the goal is remission. That is the initial thing. And the rest is just to be sure. We know that there's nausea and vomiting. We do so many things that we know today that we do before they have nausea. We prevent it. There's all different treatments today. Now, with leukemia, sometimes treatment don't work and we need to do a bone marrow. Now, bone marrows come from many places. We do have bone marrow that we save as infants, right? That's the cord blood. And we can use that as a replacement. When it's mine, it's autologous. Automatically mine's the best. Automatically mine is the best. Now, you don't have to be typed and blood typed and all that stuff for this. Usually a sibling is the next best one, but have a sibling, they can find somebody else that seems to be the best match. Allo means all the others, everybody else, okay? Automatically, mine's the best, autologous. Allogenic means everybody else, all the others. Infection is this biggest complication. Transplant is rejection. This, the biggest complication is infection with your cell stem transplants. Now, one of the things with cancer is when we give these chemos, they're great. And in that induction period, we're killing good cells, bad cells. But what happens is we're going to be looking at neutrophils. Neutrophils are really also put under a lot of stress and their numbers can drop. Usually 2000 is a number, at least. It will drop 500 and below. Now, doesn't mean your kid has to have cancer. There are other overwhelming sepsis type things that happen with kids. If you have any child with a low neutrophil count, 500, 400, and has a fever already, that is a child who is going to crash and burn quickly. That's your first one to see. If you're having a setup of this many, which one do I see first today? The one with the low neutrophil count. We know that in cancer, that 5 to 7 day after the beginning of chemo is exactly where their neutrophil count's the lowest, and we need to be really careful. Wear a mask. We have to, their whole immune system is gone. Wearing gloves, washing hands, et cetera, et cetera. Now, there's two types of lymphoma. Hodgkin's, they make a Hodge, all right, or a lodge, and it's large, firm, and it's non-tender movable, usually from the shoulders up. You'll see these big lumps in the neck. That's Hodgkin's. Now, non-Hodgkin's is not a house, not a lodge. It's like diffuse all over the place. It's nothing, but it's everywhere. So Hodgkin's will probably do a biopsy, we'll take it out, radiation, right? It's pressing sometimes on the throat, might be a cough. Non-Hodgkin's, not a house, that means they're diffuse, they're all over, they're everywhere. And again, that one would need chemotherapy to get rid of it. Brain tumors happen in children. What do we see? These children are going to have nausea, vomiting, and headaches that get worse. You'll have headaches that wake them up at night. You'll have vomiting not related to feeding. This is all part of brain tumors in children. Remember, if they have somewhere in the brain where they have a little purple mark, radiation, never, ever, ever wash off those marks. They'll do that because that's where they're going to put the next radiation. Wilms tumor is a kidney tumor. It's also called a nephroblastoma, and it is a highly it's every movement can create little micro pieces to be burst off into the abdomen and metastasize. So this is the one you wouldn't touch. I've seen one in my career, and I actually found it on triage. And it was the right lower quadrant, and it was about the size of a softball. And this kid was 3 years old. We don't do biopsies on this because if we punctured it, guess what? Those cells are going to go and metastasize. Big, big nursing thing. Kidney tumor, nephroblastoma, Wilms tumor, do not palpate the abdomen. Leave it alone. Once they do chemo, maybe radiation, they take it out. These kids do well as long as we've done our jobs. Remember your CPR. You'll always see a CPR on an exam. You saw one on exam 1. You're going to see one on exam 2. We know that the kid's not, unresponsive. We know that we're going to start chest compressions. We know if they're choking, we could do abdominal thrusts. Remember, it's all, and then call for help. That's your whole log. We have all of these cahoots. You have a hold of them. There's always 5 dosage calc. Anybody who needs any help with dosage calc, ask me and I will help you. I do have videos. I do have handouts, whatever you need. So that's all I have. I wish you the best. You're going to do good.